Immunological aspect of transfusion reaction. The field of cellular therapy is an active domain of basic research, clinical practice. It requires a highly controlled quality process to ensure product safety. Modern transfusion medicine is a clinically oriented subject combining the traditional field of immunohematology, the blood component supply, the novel challenge for patient care treatment. Blood bank physicians are recently more involved in designing appropriate transfusion strategy with clinicians. Immunologically mediated transfusion reaction cause of immunological incompatibilities. Each blood cell has many different engines on its surface. Donor plasma may contain proteins that are foreign to recipient. Donor plasma may contain antibodies incompatible with antigen on recipient's cells. Immunological complication of blood transfusion: incompatibility to red cells, hemolysis, intravascular APO, extravascular rhesus factor, white cells, platelets, plasma protein, immunomodulation, beneficial and detrimental. Immunological complication of blood transfusion: site of destruction and predominantly intravascular, predominantly extravascular. Characteristic of antibodies: potent anti-A, anti-B, antibodies that don't activate or only partially activated, complement, anti-rhesus, anti-K, anti-GK, anti-other. Symptoms: sternal pain, lumbar pain, and restless, nausea and shivering. Sign: immediate hypertension, fever, uncontrolled bleeding, and hemoglobin urea. Here the symptoms: nausea, predominantly extravascular, nausea, shivering. Signs: fever, jaundice. Later, hemoglobin urea or jaundice. Immunologically mediated transfusion reaction: a part of red cell engine, leukocytes and their metabolic product, cytokines, are highly involved. Recent efforts improving the safety of blood products are mainly focusing on reducing white blood cells count in cellular blood products. Factors responsible for immune-mediated transfusion reaction: complement protein, cytokines, adhesion receptor, measure histocompatibility antigen, measure histocompatibility antigen HLA, immune response to donor cellular antigen. Accumulation of significant quantities of C3A in donor complement proteins, blood component due to contact with non-biological surface of storage plastic blood bags, contribution to anaphylaxis and immune suppression by blood transfusion. Pro-inflammatory cytokine: interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor can be produced by a recipient or donor activated leukocyte. Donor leukocyte during red blood cells platelet storage: interleukin 1, interleukin 8. Cytokines released during platelet storage: residual donor leukocyte in platelets synthesize and release various biological response modifiers including cytokines. Release cytokine accumulate in the plasma of platelet concentrate during storage reaction. Adhesion receptor: adhesion molecule include selectin, integrin, immunoglobulin like supergene family. Role during transfusion reaction: ruling, tethering, adhesion, transmigration of neutrophil across endothelial cells. HLA antigen: alloimmunization to donor class 1 measure histocompatibility. Antigen is one of the major immunological complications of blood component therapy. Class 1 MHC antigen can efficiently processed by antigen presenting cell of transfusion recipients. Direct interaction between donor leukocyte and the recipient immune system. Alloimmunization to donor MHC antigen. Immune receptors immune response to donor antigen. Development of immune response to transfused platelet depend on the interrelationship of donors' transfused antigens. Presenting cell with recipient T lymphocyte, monocyte, macrophage, dendritic cells, epithelial cells. Antigen recognized by recipient T cell appropriate signal to recipient B lymphocyte, plasma cell, antigen specific allo-antibodies, long-term platelet transfusion therapy, platelet alloimmunization. Platelet become refractory to platelet transfusion from random donor. BTs will require HLA compatible platelets transfusion. Patient become refractory to platelet transfusion from random donor. Patient will require HLA compatible platelet transfusion. Alloimmunization and refractoriness to platelet. Alloimmunization and refractoriness to platelet. The management and prevention of alloimmune reaction. Poor post-transfusion increment. Patient receiving multiple platelet transfusion from random donor become immunologically refractory. Circulating lymphocyte antibody directed against HLA and AG is a reliable serological marker for alloimmunization in multiple transfused patient. Leukodepletion remove different type of allostimulatory leukocyte, prevent development of alloimmune platelet refractoriness. Circulating lymphocytotoxic antibody directed against HLA-A or B antigen is a reliable serological marker for alloimmunization in multiple transfused patients. Leukodepletion remove different type of allostimulatory leukocytes, prevent development of alloimmune platelet refractoriness. Hemolytic transfusion reaction, non-immunological mediated transfusion reactions. Immunologically mediated transfusion reaction, hemolytic transfusion reaction, non-hemolytic febrile transfusion reaction, allergic transfusion reaction, transfusion associated graft versus host disease, transfusion related acute lung injury. Non-hemolytic febrile transfusion reaction, common in patients whose plasma contain potent leukocyte antibodies due to previous blood transfusion or pregnancy. Foreign leukocyte antibodies destroyed by complement activation C3a, C5a, and are engulfed by a host monocytes. Release of cytokine and pyrogeny. Non-hemolytic febrile transfusion reaction may occur due to transfusion of stored platelet concentrate due to release of cytokine by leukocyte, usually mild, and can be deleted by slowing the transfusion and the administration of antipyretic. Leukodepletion is sufficient to avoid NHFTR, non-hemolytic febrile transfusion reaction. Transfusion associated graft versus host disease, infrequently but potentially lethal immunologically mediated disorder which occur when variable donor to T cell in blood product engraft in immunologically compromised recipient. Implicated cellular product are WBCs, RBCs, platelet concentration, fresh plasma, frozen plasma products. Diagnosis: clinically based. Skin histopathology shows lymphocyte infiltration and dyskeratosis. Clinical signs: fever, skin rash, diarrhea, hepatitis, and mouth failure begin 2 to 50 years after transfusion. Prerequisite necessary for development of graft host D, GVHD. Graft versus host reaction. Donor blood component must be contaminated with viable T lymphocyte. Recipient must express T antigen MHC which are not present in blood donors. Recipient immune system must be unable to recognize and destroy the allogenic T lymphocyte. Host tissue damage occur due to release of tumor necrosis factor, TNFB and IL by the donor, cytotoxic T lymphocyte and the natural killer cell. GVHD may also occur in immunocompetent patients receiving cellular blood component from first degree relatives. Host tissue damage occur due to release of tumor necrosis factor in FB and IL by the donor, cytotoxic T lymphocyte and natural killer cell. GVHD may also occur in immunocompetent patients receiving cellular blood component from first degree relatives. GVHD may be exacerbated by herpes or cytomegalovirus infection. Such infection may include alteration in immune regulation in the host and provoke alteration on cell surface, increasing susceptibility of host target cell to attack by effector cells. Can't be prevented by leuco reduction. Gamma irradiation remain the standard method of prevention. TGVHD, graft-host reaction. Transfusion-related acute lung injury is a rare complication of blood transfusion, occur within 6 hours of BT, blood transfusion. Clinical picture: insidious onset of pulmonary insufficiency, severe dyspnea, hypoxia, pulmonary edema. Transfusion-related acute lung injury pathology: infusion of anti-leukocyte antibody, activate complement cascade, white blood cell stasis in pulmonary vein, neutrophil mediated lung injury. Treatment: supportive and discontinued transfusion. Reaction to plasma: mild urticaria may occur in 1 to 3 of plasma transfusion due reaction to donor plasma protein and corresponding IgE antibodies in the recipient plasma. Severe anaphylactic reaction occur in IgA deficient recipient. Detrimental effect of immunosuppression, role of blood transfusion: increased rate of post-operative bacterial infection, increased rate of recurrence of colorectal carcinoma, survival of renal allograft. Leukocytes are the favored